Those are my disclosures, and there are none. And I thought we would talk about some of these issues. My intention is just to give you a pearl here and a pearl there, just sort of skidding through various aspects of geriatric assessment. Is there something else that you would want to cover in geriatrics other than what's there? Anybody have any other issues that concern them? Driving. Okay, we'll try to bring that in if we can, because it's got a whole hour and it's on its own. Sure. Okay. So first of all, I just want to wrestle with this issue of frailty, because I've had trouble with that concept of frailty through the course of my career. It's one of those very subjective terms like pretty or cool or something. Exactly how do you define frailty? And is frailty a biological entity or not? Is this man, for instance, frail? This is a man who attended our day hospital in Prince George. How do we define it, and what are the implications of frailty? And I don't know that the Canadian study on health and aging actually did us any favors. They made this scoring system. You've probably used it, some of you, I'm sure. And it's basically entirely based on function. So, for instance, somebody is said to be moderately frail if they need assistance with basic ADLs and with IADLs. But that, you could have say a 55-year-old woman with MS who could be at that level of frailty, and you could have a 92-year-old man with no comorbid disease who's frail, and surely those can't be the same thing, biologically speaking. And I think they're not. I think there is specifically a senescent frailty, and that's what I wanted to address, is the issue of senescent frailty. Now, every organism eventually goes into a senescence, a phase of senescence near the end of their life cycle, whether it's a fruit fly or whether it's a roundworm, whatever it is. Somewhere along the line, the telomeres on the chromosomes are exhausted, and the chromosomes stop replicating, cells stop replicating, macromolecules stop being produced, and the organism goes into this phase of senescence, in which they are quite vulnerable to morbidity and mortality. At least in research, this biological or senescent frailty has been defined by these 5 characteristics. And you must have 3 of the 5 present in order to say that a person has senescent frailty. So self-reported exhaustion, slowed performance, usually measured by walking speed, weakness, usually measured by grip strength, unintentional weight loss of 10 pounds per year, and low physical activity. And we assume that not explained by other sorts of pathology. Senescent frailty is associated with a high risk for morbidity, mortality, hospitalization, institutionalization. One of the defining characteristics of frailty, and you'll see quite a lot of research now going on sarcopenia, which is in particular the loss of muscle tissue. So sarcopenia is one of the defining features of senescent frailty. There's only limited treatment available for it. If your telomeres have exhausted themselves and your cells aren't dividing, you can't really change that in any way. You can try to remediate to some extent through increasing the intake of calories and protein, and by the use of exercise. So there are other markers of, yes?
Many years ago, we used to use anabolic steroids to try and build muscle mass in frail elderly.
So, well, I've tried. Anabolic steroids is the question, and I think I've tried everything I can think of to deal with senescent frailty, such as the anabolic steroids, usually deletestrel, something like that. I've tried Megace to try to stimulate their appetite. I've tried regular testosterones. I haven't found any of that helpful, and I've basically given up and just go with diet and exercise. There are other features that occur during the course of senescent frailty, and these are some of them. The albumin goes down, and inflammatory markers like CRP go up. And those two usually go in lockstep, don't they? Because albumin is basically a negative acute phase reactant. The total cholesterol level goes down, and so now you get into this paradox where in people your age, having a low total cholesterol is a good thing with a good prognosis, but having a low cholesterol when you're 80 is a very bad prognostic feature. So the optimal total cholesterol level moves up to about 6 in the aged. The weight goes down, but also the optimal weight for health goes up. So that although, the normal weight is said to be in the BMI range of what, 18.5 to 25, the optimal range for the elderly is about 26. And you'll see from this that people who are overweight, that is to say 25 to 30, as compared to people with normal weight, the overweights have a lower mortality rate than the normal weights. And the underweights have a 76% greater mortality than those of normal weight. So it's good when you're elderly to have some meat on your bones. Just don't get it too early in life. I figure I'm at a point now where I should just start pigging out at this point. So, sarcopenia. This man has definite sarcopenia, and the best place to see sarcopenia is at the temporalis muscles here. And I always look for this when I meet a patient. The temporalis muscles, there's no disuse atrophy involved. It's not like other, say, leg muscles or arm muscles. We all use our temporalis muscles, whether we're young or old. So when you see these wasted, hollowed out temporalis muscles, you know that the patient is sarcopenic. So there's one little pro for you. And if you were to choose a marker of vitality and a prognostic feature for the elderly, let's say you took a bunch of people at age 70 and you want to try to figure out who's likely to live the longest, what would you look at? What would you measure? Would it be hemoglobin? Would it be creatinine? Would it be cholesterol? Would it be BMI? It turns out in repeated studies that the single factor that correlates best with longevity is walking speed. I often reflect on that as I'm walking around the hospital corridors stuck behind visitors, and I'm thinking, my God, your longevity is crap. Well, so let's talk a bit about assessment of gait, and I think at this point I might leave the podium if I may. So I've just got to make the appeal to you that when you're doing your physicals on your elderly patients, you want to actually do the get up and go maneuver, not the timed get up and go. I don't think there's any point in measuring it in seconds, Just do the get up and go maneuver where you get the patient to walk down the hall and back and watch them. But watch them with some discipline, deconstruct what they're doing and take notes specifically of what they're doing. So I thought we'd just talk about that for a moment if we could. So let me just come down from here. I hope you can still hear me if I do. And maybe Lisa, could you just come? So what I would do is I for instance, don't have my patients weighed ahead of time. Thank you. Go ahead and sit down. So I have to take the weigh scale, so I usually do this as part of my physical exam. I've done the history, I've done the cognitive testing. Now we're going off to the examining room to examine the patient, and so I'll get them to do this on the way to the weigh scale. So just ask the patient to stand up for you, so if you could stand up for me, Lisa. And now, would you walk fairly briskly down there for me? Okay, stop and come back. Okay. All right. So, but now let's go through it again. So, stand up for me. Now, a lot of my patients would have a great deal of trouble doing that because these are chairs without arms, and my chairs would always have arms because they're usually needed. But the fact that she can launch from a chair, we call that the launch, by the way. The fact that she can launch from the chair without using arms would be a wonderful thing, rarely seen in my practice. Just stand away for a second. Now, the other thing that you might see is the typical Parkinsonian kind of launch, which would be where the patient, you ask them to get up and they do this. And usually on the third time, they sort of pick up their amplitude each time, and finally they make the launch on the third time. They have trouble initiating movement, people with Parkinson's disease. So just walk down there again if you would for me. So go ahead, fairly briskly down that way. So, okay, stop. So the things you want to watch for would be the striding. You want to specifically take note of the striding. Is it a short stride, barely, one foot barely clearing the other, or is it a long stride? What is the width of the base? Is the person widening the base in order to improve their balance? Are the arms swinging, and are they swinging symmetrically? So, normal people would swing their arms. A person who's got a stroke on one side, and it may be very subtle. It may just be that this arm isn't swinging as much as the other arm. Or a patient with Parkinson's disease, and Parkinson's is virtually always asymmetric. Parkinson's happens more on one side of the body than the other. So a person with Parkinson's, well, first of all, Parkinson's patients would be forward flexed. They would have a narrow base and a short stride with very little amplitude to their steps. So, and one arm would be swinging less than the other. And then the next thing you want to watch is I commanded her to turn around. And that was quite deliberate. So go ahead and walk again. Arms at your sides. Yeah, okay. And now turn and come back. So a lot of people, elderly people on the turn, they'll say stop and stop. And you'll say turn around and they'll break it into 4 or 5 steps, where I should push you, of course, to a nice fast pivot and swim. So look at the turn. And if the person's ataxic, and ataxic, of course, means like staggering, drunken staggering, usually the turn will bring on a stagger, and they'll stagger sideways a little bit on the turn. Now come on back. And now come on right back to you. The next thing I do is when she's back is I'm going to do the Romberg. And so would you put your feet together, touching for me? Now we'll come to the side, and maybe I'll do this on. And just put your arms to your sides now. I'm just going to do it with eyes open first, because a lot of my patients, even with their eyes open, when they put their feet together, are going to fall down. And I'm right here. I'm not going to let her right there. And now close your eyes and stand still. And note, of course, whether they're going to fall, and I have to intervene, but also the degree of sway. And sometimes I'll say Romberg negative, but sway plus, plus, plus. Okay, that's fine. Okay, so that was for her, not for me, I'm sure. Thank you. So there are some different gait patterns that you're going to see. And so let's just talk about a few of the most common gait patterns. Probably the most common would be the antalgic gait. So that's a painful gait. Sometimes they break gait disorders down into lower level gait disorders and higher level gait disorders. That is to say, things wrong with the legs, usually bad joints, lower level gait disorders. Higher level gait disorders, things wrong with the brain, with the CNS. Probably the most common of the abnormal gaits would be the antalgic gait, a painful gait, a limping gait, a hobbling gait. And just watching the patient do that, it's very subjective, but I think you'll usually get the idea whether they're having trouble walking because of bad joints or bad neurology, to put it simply. Okay. And keeping in mind, too, that in geriatrics, we often say that in geriatrics, the most common cause of anything is multiple causes. Because everything's all mixed up. It's a mix of different pathologies going on at the same time. So we can't expect to see a perfect, pure case of any kind of gait. So we've done the get up and go. There's a few optional tests that maybe I'll mention. These are ones that I wouldn't do on every patient. I would do them occasionally. At least on. Now, one would be retropulsion, or it's sometimes called the tug test. And it's specifically used on Parkinson's patients because they have a hard time with it. So I come behind after I've done the Romberg, feet apart this time a little bit, yeah, like that. Get your balance and don't let me knock you off balance. Okay, that's the tug test. And it's even measured in terms of the number of steps back, either a full or the number of steps back. Parkinson's patients have a really difficult time with that test, the tug test. Other optional tests that you might do might include the tandem stance and tandem gait. So tandem stance is just where you stand one foot in front of the other, whereas tandem gait is the one where you do the heel to toe walking. Dangerous in the elderly, quite frankly. I mean, you've got patients of all ages, so you might want to do it in your younger patients, but you'd be lucky to get tandem stance out of an elderly person. Then sometimes I might do unipedal stance, so the ability to stand on one leg, and then the ability to stand on the other leg, and occasionally functional reach. So, and physiotherapists do this. They'll have the patient put their hands out, and they'll actually measure it and say their functional reach is so many inches, because some will just fall over when they try to do that, and you're there to intervene. So those are a few extra balance tests that you might use. Any questions, comments? I know we have 10 minutes at the end, but I'm very happy if we just have the interaction all mixed through this. Okay, so some common gait patterns. The antalgic gait we talked about, the hobbling, limping gait. The cautious or senile gait, as it's called, is a very common one that you'll see, usually in your frail, older people. And it's the one where people are obviously uncomfortable walking, and they'll get up and they'll widen their base because they want to keep their balance as well as they can. They'll hold on to just about anything that they can hang on to, door frames as they go through doors, and they usually have their hands outstretched like they're waiting for a fall at any moment. It's not really a neurological gait. It's a gait caused by multiple deficits, usually a combination of visual problems like macular degeneration, a little bit of chronic vestibular difficulty, maybe some sensory loss in the feet with the proprioception starting to go in the feet. So the cautious or senile gait. Then the Parkinsonian gait I pretty much demonstrated for you. And you might want to actually go to the shopping mall and just start looking at people walking up and down. It's great fun. And there's lots of pathology there. And my wife and I do this all the time. And I've got her trained now, so she said, that one's got Parkinson's, right? And I sometimes want to go up to people and I want to say to them, do you know you've got Parkinson's disease? And I bet you a lot of them don't, because there's a usual 2 to 3 year delay to diagnosis with Parkinson's disease. Okay. Now the frontal gait pattern, and that takes a little bit of explanation, but it's one that you see quite often. And we're not totally sure why it's called the frontal gait pattern, because it's not usually associated with frontal pathology. It's usually associated with subcortical pathology. But this is the gait where you've got a short stride, but not shuffly steps, sticky steps, sometimes called magnetic, like you have to pull each foot up off the ground and then place it down again. And you can hear them coming down the hall behind you because they go plop, 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 coming down the hallway. Usually a manifestation of subcortical ischemic vascular disease. Now, that's what used to be called Binswanger disease. So that's, and you see it on CAT scans all the time of heads. They'll say something like there's reduced attenuation in the periventricular white matter consistent with ischemic white matter ischemia. So that's called leukoariosis. That's the proper name for that. And then chances are the patient will have a bunch of those lacunes as well. So this person has got, in addition to the reduced attenuation like here and here, there are lacunes here, here in the caudate, down here in the basal ganglia, and so on. So this combination of leukoariosis and lacunes may be associated. It's very nonspecific, and there are some people with that who will be actually totally asymptomatic, but that is often associated with that so-called frontal gait pattern, also sometimes called gait apraxia. These people, and there's lots of them around now because, back in Binswanger's day, it was a rarity because vasculopaths died, and these are vasculopaths, and now vasculopaths don't die anymore. They just get stented and they go on and on and on forever. So we've got lots of these people with this subcortical ischemic vascular disease around now. They also have this pattern of cognitive slowing in particular. So they've got cognitive problems, but a different pattern of cognition from that you see in Alzheimer's disease. Alzheimer's, you just get that episodic memory loss. Did you ask me to remember 3 words? Whereas these people, it's more slowing of cognition and trouble with retrieval. So give me a hint. Oh yeah, it was something to wear. It's a shirt. They have trouble accessing the memory, but they can actually make the memory just fine. Okay. The spastic gait, I think you recognize that one. Usually the arm held here and the leg on that side stiff, and doing this usually inverted and down like that, right? And occasionally you'll see the same thing bilaterally, fairly rare, but one situation in which you see that you should probably know about and look for is cervical spondylotic myelopathy, okay? That's cervical spondylotic myelopathy. That's basically spinal stenosis, but at the neck level. So spinal stenosis in the low back, you get lower motor neuron weakness in the legs because it's below the conus. But if you get it up in the neck, you'll get spasticity and upper motor neuron signs. Okay. Foot drop, you'll see that a lot in the elderly. You recognize that because these people will deliberately lift their leg high so that toe clears the ground. And then the ataxic gait, which is the drunken staggering gait, which appropriately, is nearly always due to alcoholic cerebellar degeneration. Okay, any questions about the get up and go or the assessment of gait? Anything about that, or falls, for instance? I've got a little bit of information here on falls. I wanted to mention a few things. I get asked to assess people with falls quite a lot, and sometimes you do them, and they've got a negative examination, you can't find anything. They can do tandem walking. Their Berg balance test is 56 out of 56 when the physio does it, but they're still falling. In that situation, check their cognition, because one of the biggest causes of falls, maybe this is a pearl for you today, one of the biggest causes of falls is actually impaired cognition. And I'll say to my physiotherapist in the day hospital, everything's fine, why is she falling? And she'll say, well, yeah, she does the dumbest things. You know, she gets to something in her mind to do, and she'll just hop over obstacles and not the slightest bit of caution. So before you get out the requisition and order Holter monitors and expensive things like that, maybe just do a MOCA test on some of these patients. So another point is that in Alzheimer's disease, so when I'm assessing Alzheimer's patients, what I want to see is an absolute pristine neurologic exam. There are no abnormalities in early Alzheimer's disease. And their gait is normal. There are gait problems in later disease, but in early disease it should be perfectly normal. And if it isn't normal, if you're doing a dementia workup and you find an abnormal gait, look for something else. Maybe it's vascular, maybe it's normal pressure hydrocephalus, but it's not going to be Alzheimer's disease. Okay. Cognitive decline, we got that. Here's something, I'm not sure if you're aware of this, but antidepressants contribute to falls. So this is taken from a meta-analysis, so it's got a lot of N behind it. Antidepressants have a risk ratio of 1.68, so you're 68% more likely to fall if you're on an antidepressant. And SSRIs are at the top of the list. Tricyclics, SSRIs, it doesn't matter. And I do worry about this because just about everybody seems to be on citalopram these days. I don't know if you noticed that, but just about everybody who comes to see me is on a proton pump inhibitor and citalopram and aspirin. They might as well just make a poly pill that has all of those things in it because everybody seems to be on it. And I worry a bit about that. Okay, so the antidepressants increase the risk of falls, and you'll see that they increase it as much as benzodiazepines do, or more, as much as sedatives and hypnotics do, as much as antipsychotics do. So antipsychotics increase the risk by about 1.59 or 59%. Typicals and atypicals are the same, no difference. And if you're on two different psychotropic drugs, like an antidepressant and an antipsychotic, then the risk goes up by 2.5. So here are some other drugs that may cause falls. Antihypertensives have a lesser effect on falls, 24% increase, and ACE inhibitors actually being the worst of the pack. And I don't know the reason why beta blockers have a slight protective effect, but they do, and that's being repeated in several different studies. Narcotics, oddly, do not increase the risk of falls. You'd think they'd be stumbling around stoned, but there in fact is no increase in falls rate in the average patient on narcotics. And alcohol and falls, well, it's just like alcohol and anything else. People who drink a little bit seem to do better than the rest, and people who don't drink at all are worse. And people who drink heavily are worse still. Here's the latest on vitamin D based on a recent meta-analysis, and I'm sorry I didn't give you the reference here. So vitamin D reduces the risk of falls by 19%. This was based on a meta-analysis that involved over 2,000 elderly patients. The number needed to treat was 15. But there is a dose response, and you may need a higher dose, like 800 to 1,000 units of vitamin D in order to get this effect. So if we are going to have a poly pill, I say that we put the vitamin D in the poly pill and maybe take out the citalopram.
Do you know the mechanism?
Well, there are vitamin D receptors on muscle. There's vitamin D receptors in many tissues. Even there's some cancer-preventing effects of vitamin D. I'm not a cellular biologist, I can't tell you all the details, but it does improve muscle strength.
What about bifocal glasses in the elders?
Bifocals in the elderly, yeah. Well, they increase the risk of falls. Bad vision increases the risk of falls, but bifocals in particular have consistently been shown to increase the risk of falls. And I can see why, because, when you're walking up and down stairs, you're just not at the right focal length down there, and trust me, I know, because these are variable bifocals, and in a way, I hate them.
I often comment to elder patients when they're in the optometrist, if you need 2 pairs of glasses, get 2 pairs, but whatever you do, don't get 5, and whatever you do, don't get 5.
It's true.
That's popular with the optometrist.
Because I'm not specifically delivering a talk on falls here, because we could go on for a full hour on that, but there's lots of other things too associated with falls, including cats and dogs. Sleeping cats and dogs seem to be a very major cause of falls. So I thought we'd just segue now into a bit on cognitive impairment. And I know we can't talk a lot about cognitive impairment in a session of this length, but I wanted to make a couple of points. We're all seeing a lot of people who are complaining about their memory, aren't they? Because people are much more aware now of Alzheimer's disease. It's not a shame so much anymore. People are bringing it to us early. They've heard there's treatment, etc. So when people come for assessment of their memory, basically we could end up concluding there's nothing wrong with them. Maybe they're worried. Maybe they've got a family member who's had Alzheimer's disease. Or they've got dementia. Or they fall into this in-between category called mild cognitive impairment, or MCI. So are you guys kind of up on your MCI? Are you comfortable with the idea of MCI, or should we maybe discuss that a bit? Maybe we should. Okay. So MCI basically means you're not demented, but you're not normal. So look at this graph here that I've made. So you see the top line says normal aging. So with age, there is a gradual slowing and inefficiency that comes into cognition. But it should never get down to the point of interfering with independence. So that's the level at which it would start to interfere with ADLs and IADLs and normal aging. So dementia is basically defined as cognitive impairment that interferes with ADLs, that impairs independence and function. MCI is the in-between ground where you don't yet meet the criteria for dementia because there's no loss of independence yet, but you're considered not normal for your age. Okay. So these are the specific criteria for a diagnosis of dementia. You have to have decline in 2 cognitive spheres, so that can be memory, speech, executive function, attention, visuospatial, praxis, gnosis, etc. So you have to have deficits in 2 areas to the point of causing impairment in ADLs. That's how you define, that's the cutoff point for dementia. MCI, you have to have cognitive decline in 1 cognitive sphere. It doesn't have to be memory, actually, but preservation of independence, albeit possibly with a bit of inefficiency in your functioning. So that, for instance, if you kind of know you're forgetful, but you can still use strategies to compensate for your forgetfulness, we'll say that's okay. There's no loss of independence yet. You fall into the MCI territory. The reason we want to make the distinction is that dementia we would usually treat with cholinesterase inhibitors, but also, the usual sort of dementia pathway of education and support and so on. MCI, there is no evidence that cholinesterase inhibitors will help you in the MCI stage. So that's why we're kind of working, while we're talking about this here, is to try to help you define at what point a patient might actually benefit from therapy. But MCI is a heterogeneous kind of category. There's a whole mixed bag of people in MCI. Probably the largest portion of people in MCI are just preclinical Alzheimer's disease, so that everybody who develops Alzheimer's will pass through that phase of MCI. On the other hand, not everybody in MCI is going to go on to Alzheimer's disease. About 70% will go on to Alzheimer's, so 50 to 70% will. Some will be non-progressors, and some will be reverters, but very few actually are reverters. So an example of a reverter might be, say, somebody whose cognitive impairment was due to depression and the depression lifted. Or maybe they've got sleep apnea and you finally talk them into that CPAP mask. Or maybe you replenish their B12 or whatever, their thyroid, etc. The non-progressors, there's often something that gave them sort of a single hit that then doesn't deteriorate. So take, for instance, somebody who went for a cabbage operation. Cabbage is notoriously hard on the brain, and it's not uncommon for the brain to take a bit of a hit from a cabbage in the elderly, and then often it'll just stay at that level. But the majority will progress on to dementia. Okay, so what test should we use? What cognitive test should you order or perform in your offices? Now, the MOCA, has come on the scene, and people have this message that the MOCA is the better test, so let's all use the MOCA. And it's being overused because it has its niche, and its niche is in mild cognitive impairment. It's meant to be a harder test. It's meant to be like a stress test that brings out milder degrees of impairment. Don't use it in people who actually have established dementia, or where the history is telling you, because by the time you've taken the history and you've heard that there are impairments in multiple spheres of cognition and there's significant interference with ADLs, you know that patient has dementia already. So I would just do an MMSE, or more likely a 3MS test, the expanded version of the MMSE, the modified mini mental state. So MMSE or 3MS if you're pretty sure that you're headed for dementia, and MOCA if you're pretty sure that you're headed for mild cognitive impairment. Any questions about cognitive testing? Nope. Okay. Here's a little pearl I want to leave you with, and that's about the normal results on a MOCA. So the people who developed the MOCA in Montreal said that a normal score was 26 or better. I think we're learning that it's not. So here, this has just been published within the last 6 months, the Dallas Heart Study. So they enrolled almost 3,000 people, and they did MOCAs on almost 3,000 people, and then they published the normative data from their study. These were not people who were cognitively impaired. These were just people in a population study looking at their cardiovascular health. So what they found is that broken down by educational status, so let's say a high school education, grade 12, in a person in their 60s, the mean MOCA was only 21. So it's way below what the people in Montreal say that your MOCA ought to be. So you might want to just keep that in mind when you're administering these tests. I wouldn't call somebody MCI just because they scored under 26 on a MOCA. Okay, that point's being made. So let me change topics again. I want to go on to one of my favorite rants about depression and demoralization. And I don't think you'll see this in the literature very much. I admit it's a pet peeve of my own, but I think there's a difference between depression and demoralization. Depression is a mood disorder. Demoralization is where an elderly person is bummed out over all sorts of nasty things happening to them. Their spouse has died, or the spouse has got Alzheimer's disease, and they've got painful joints, and they can't get around like they used to, and they've been told they can't drive anymore, and their vision's starting to go from their macular degeneration. And hell, life is no fun, and being elderly is like that. But is that the same as being depressed? This patient might come to your office and say, "Doc, I feel the pits. I'm really low." And you do the GDS, and they score quite high. They maybe score 9 out of 15 on the GDS. But I bring them to the day hospital because I need to rehabilitate them from a number of conditions, and they come to the day hospital and they're just absolutely the life of the party. They're having a great time. They're socializing. They can forget their problems. A person with real depression can't forget their problems. They have this pervasive low mood. The person with demoralization loves it when the grandchildren come over. The person with depression says, "Keep those kids away from me." They just can't feel that pleasure anymore. I think, although there's not a lot of science behind this yet, I think that antidepressants will work much better in depression than they will in demoralization. So again, maybe think twice before you reach for the citalopram in some of these folks. Okay, the point's been made. Another reason is that SSRIs are associated with osteoporosis. So they're there on that list of drugs that cause osteoporosis. So this data was taken from the study on osteoporotic fractures. So the normal loss of bone density per year in the elderly, 0.47% per year. It's the same if you're taking a tricyclic, but if you're on an SSRI, it's almost doubled. So it's now well established that SSRIs do contribute to osteoporosis as well as contributing to falls. So you've got a double whammy going on there. A few other drugs that are known to cause or contribute to osteoporosis. Another one that's in our polypill, the PPI. Anticonvulsants, we've known about that one for years, but even gabapentin's on the list. The thiazolidinedione, so your pioglitazone, for instance. The aromatase inhibitors being used for breast cancer now are bad at causing osteoporosis. And perhaps the worst of the bunch would be androgen ablation therapies used in men with prostate cancer. On the other hand, hydrochlorothiazide actually improves bone density and reduces fractures a little bit, as does tamoxifen. But of course, as does tamoxifen, because it's basically the same thing as raloxifene, which we use as an osteoporosis therapy. So, musculoskeletal ills. How are we doing for time? So, I think we're okay. So, I see a lot of these problems. I just thought I'd share just a few with you. Hyperkyphosis. So, these ladies who you see, usually ladies, some men, with these crooked backs, right? And you say, okay, you've got osteoporosis. Do you know, in fact, most of them don't? That the majority of people with these twisted hyperkyphotic backs, in fact, do not, 2/3 do not have any osteoporotic compression fractures. What it turns out is that hyperkyphosis is basically another form of frailty that is probably due to sarcopenia with muscle weakness that has led to the flexors taking over from the extensors, the flexors being stronger than the extensors, with a progressive curvature. It is a potent marker of frailty and predicts demise the way that sarcopenia does, for instance. The dwindles. Okay. If you wanted to measure the degree of kyphosis, you would do the wall-to-occiput distance, measure the distance from the person when they stand up against the wall. I don't think you folks would really want to do that, but you can measure it. Here's a key message. These people, mostly ladies, are going to complain of shortness of breath. Don't give them Lasix. It's not going to help, and I see that happen all the time. That's the usual response when an elderly person comes in and says, I'm short of breath. They get Lasix. These people have restrictive lung disease. Their lungs are all scrunched in there. The bellows can't bellow anymore. And if you talk to them, they won't actually usually say, I'm short of breath on exertion. They're more likely to say, I can't get a satisfying breath. And they'll want to do these sighings or breaths. So hold the Lasix when some of these folks complain about shortness of breath. Here's something you won't see in any textbook, and I have no idea why, because it's a terribly common problem, and that's rib-on-pelvis pain. So these ladies with the crooked backs and the scrunchy lungs, maybe Lisa, just if I could borrow you again for a moment. You know, normally, just turn your back to me if you wish. Normally, if you were to feel a person, go down to their lowest rib, and then you can put 2 fingers. In fact, I can almost do 3 here I can do 3 fingers here on Lisa, between the lowest rib and the pelvis. These ladies are actually hitting the pelvis, and it hurts. And so when they come in and they say, Doctor, my back aches, and usually they say that, oh, doctor, my back aches, like this. Maybe don't order an x-ray. Just come in here with your hands and just reach in for those lowest ribs and give them a bit of a squeeze and see if the patient jumps, because they'll tell you that, they'll tell you that hurts. What can you do about it? Well, maybe you might have to talk to your OT and your PT about it, because there's a limited amount you can do. You know, having an armchair that has arms on it that they can actually offload a little bit of the weight is one thing, and maybe having transfer pulls, because every time a person gets up from chair or bed, you know, they scrunch the ribs down there into the pelvis, and maybe a transfer pull might help that. Rib-on-pelvis. Rotator cuff tendinopathy. So bad shoulders. You know, so many elderly people have bad shoulders, but probably 8 times out of 10 it's rotator cuff tendinopathy. 2 times out of 10 it might be glenohumeral joint arthritis. But shoulder arthritis is actually not a terribly common form of arthritis, whereas rotator cuff tendinopathy in the elderly is close to universal. So that supraspinatus in particular gets kind of ratty and partial tears and inflamed. So and a lot of elderly people have just been told, oh, you've got arthritis, whereas in fact, they often do respond well to cortisone injections into the subacromial space. There are really probably only two tests you need to confirm that it's rotator cuff. So there's the empty can test and the drop test. So Lisa, I'm sorry, but I need you again. So on the drop test, you basically just raise the person's arm. You're usually doing range of motion or something, and then you say, okay, now lower your arm for me. And of course, if the rotator cuff is completely torn, what's going to happen is just bang, it's going to fall to the side. And the other test is the empty can test. So like you're emptying a can of beer. So you put your hands in this position like that, and then pull down on the arms. So resist me when I do that. So that will usually bring out the pain of supraspinatus tendinitis. So those two tests are basically all you need to confirm that it's supraspinatus tendinitis. And I inject a lot of these, and in general I do a lot of joint and soft tissue injection. There's the landmarks. You want to just feel the end of the acromion process. Let's give Lisa a break, and you just can stand up for me. So just feel the end of the acromion process here. There's the end of the acromion. Come a little bit to the back because of the shape of the humeral head. There's a little bit more access behind. So feel the acromion, come back here just a little bit, make a mark on the skin. I use the cap of my needle to just press and make a little mark on the skin. And then slide in there in a perfectly horizontal fashion, point them in that direction. And it helps people, and especially in the elderly. And I don't worry very much about, well, is it going to cause a rupture of the tendon or not? These are people towards the end of life, usually. These are not young baseball players. And they need that shoulder because, my physiotherapist in the day hospital is telling me, Dr. Drummond, do something, inject that shoulder. We can't get anywhere in therapy. She can't use her walker because her shoulders won't work properly. She can't get her tops on because her shoulders won't work properly. Okay. Any issues around that? Lumbar spinal stenosis. Boy, is that ever common in my world, and I bet you it is in yours too. I think when I finished medical school, I didn't even know this existed, but boy, you just can't shake a stick at all the people now with lumbar spinal stenosis. But maybe you need to look for it in a slightly different place or slightly different way, because often they aren't complaining of back pain at the time. They will all acknowledge that they've had a bad back for years and years, but they're often not complaining of back pain now. Their pain is down in the legs somewhere, sometimes around their ankles or wherever, and it's often asymmetrical, often one leg hurting more than the other, sometimes with paresthesia and numbness, but not always. You'd kind of expect them to have lower motor neuron signs like weakness and diminished reflexes. They don't usually. Usually the neurologic exam is completely normal. But it's good to identify them because they do tend to respond fairly well to those epidural steroid injections. So I refer them to our pain clinic, and one of the anesthetists will do epidural steroid injections, which are modestly, if only temporarily, effective for them. Here's a few just interesting tidbits about lumbar spinal stenosis. Because the spinal canal is a little bit bigger in flexion, people like flexion. They tend to walk a little bit leaning over, for that matter. And because they like flexion and they dislike extension, they don't like to lie on their back because the spine is more extended when you're on your back. They like to lie on their side where they can curl up. They don't like to walk downhill because you're more extended. They do like to walk uphill where you're flexed a bit more. They don't like to use a treadmill, which extends you, whereas they do like to use an exercise bike, which is done more in flexion. And they love shopping carts at Zellers. This is another pet peeve, or rant of mine is about Zellers and the shopping carts. You walk through Zellers on any given day, and you'll see all these older ladies, and they've got their shopping cart. There's nothing in the shopping cart, or maybe there's one little item in there. They've got their elbows on the shopping cart, and they're bending over the shopping cart, pushing it along like this. Just Zellers is covered with them. And it's because they can offload their joints. It could be hips and knees, but it also could be the spinal stenosis. So watch for the Zellers phenomenon. I hope Target does as well for us. I hope they supply the buggies the way that Zellers does. I also inject a lot of pelvic ligaments. So this is a very common problem in my world, in the elderly, where they get enthesitis or inflamed ligaments. And in particular, the two that are always getting inflamed are this one here, the long dorsal sacroiliac ligament. It just follows the sacroiliac joint down. And this one here, which is the iliolumbar ligament, goes from the pelvic crest over to L5. And you feel just fairly exquisite tenderness right over those areas. And it's caused by asymmetrical forces on the sacrum. You know how the sacrum's kind of like the keystone in an arch, and if the forces on it are asymmetrical because your back's crooked or one leg's longer or whatever, you get a chronic inflammation in these ligaments. And I inject them with cortisone. It's a good deep injection. It's quite safe. There's nothing down there that you're going to run into. I mean, you stay well away from the sciatic notch, which is way down there. So I do a lot of those with quite good results. And I see a lot of people who come to me and they say, I can't walk, I've got pain, I've got arthritis in my hip. And really they don't. They have bursitis. They've got trochanteric bursitis as their main problem. They're all women. I've injected hundreds of these. Every one of them has been a woman. I don't think men get trochanteric bursitis as far as I know. And injection works very well on these folks. Just you don't use any landmarks. You just find the tender area and mark out all the tender region, and then you go and infiltrate it down deep. Just sort of go down with your needle until you just hit bone, and then back away a little bit and inject, and just keep doing that through the whole area that's involved. Okay, so here's another segue here into medications, which is the last topic. But does anybody want to go back to anything we've covered so far to talk about before we go on? Okay. So I just thought I'd let you know that the Beers criteria have just in the last month or two been updated. So if you're not familiar with Beers and his colleagues came up back in 1991 with this list of potentially inappropriate medications for the elderly. They revised it in 1997. And now the American Geriatric Society has thrown their lot in with Beers and colleagues, and they've essentially done with this what people do with practice guidelines, where they've actually got now to the point of saying this is level 1 evidence, level 2 evidence, and 3, and grade A, grade B, etc., strength of recommendation. So I think we can have a lot more faith in the Beers, the AGS Beers criteria now. So I just thought I'd share with you a bit about that. You probably want to bookmark the website where you can find the Beers criteria, or get the article that's being published in I forget which journal. And the Beers drugs are now classified in three groups. So there's one is the main group of potentially inappropriate drugs for the elderly. The other is potentially inappropriate for certain diseases, like say heart failure, for instance. And the third is a list of drugs that should be used with caution in the elderly. Now, some of the potentially inappropriate medications won't surprise you, I think. Although you'll probably reflect and say, okay, I've got quite a few patients on these medications. And believe me, I have a few too. So the anticholinergics, for instance, anything anticholinergic, the first generation antihistamines, the tricyclics, benzodiazepines of any sort, Demerol, and NSAIDs. And I'm sorry to say that after the last talk, who was kind of pro-NSAID, but if you hear it from a geriatrician, they're definitely anti-NSAID. Maybe a few drugs that might surprise you, though, that are on the Beers list of inappropriate medications would be ones like nitrofurantoin in chronic administration. In chronic administration, they don't actually say for acute administration, but it's over the peripheral neuropathy issue that you get with chronic administration of nitrofurantoin. Terazosin, well, I bet we've got a lot of patients on that one. Amiodarone, you see an awful lot. Digoxin at greater than 0.125 milligrams. Spironolactone at greater than 25 milligrams. All antipsychotic drugs, typical or atypical. Glyburide, but Diamox is okay. Insulin by sliding scale, not in hospital, but for home usage. And metoclopramide. And I fully agree with metoclopramide. It's just the most awful drug, and please never give it to an older person. Just horrible EPS syndromes that you get with metoclopramide. Any thoughts on this? It's kind of scary because you've all got patients on these drugs, don't you? I mean, elderly patients on these drugs. But maybe, maybe the message is, okay, if they're on one and you've tried to get them off it, but you can't, okay, live with it. But if you find that your medication list has got 2 or 3 or 4 of these drugs on it, you really have to give your head a shake, maybe. And another thing is, if you work in nursing homes, you might actually want to do audits in your nursing homes using the Beers criteria to say, okay, what is our exposure to Beers type drugs on average? Here's the second group, the ones with drug disease contraindications. So for instance, in heart failure, not recommended to use a COX-2 inhibitor or one of the, are those DHP or non-DHP calcium channel blockers? I can never remember. Or glitazones, like pioglitazone. And if the patient has a syncope history, then not using the cholinesterase inhibitors, the Aricepts and so on. For seizure disorders, and I don't think I knew this one, but I see that in seizure disorders they say you shouldn't be using either olanzapine or tramadol. I didn't know that. And in falls, you'll see that for patients who have a history of falls, don't use SSRIs and antipsychotics. Just echoes what we said earlier in the presentation. And for CKD, not to use triamterene. Now, I've known that for a while, so that's the potassium-sparing agent that's in diazide, and it causes interstitial nephritis. And drugs to be used with caution, well, ASA for primary prevention, but only a weak recommendation. Dabigatran for atrial fibrillation for anticoagulation. And I think that's largely based on the renal issues, because there have been a lot of mishaps with dabigatran because it's renally excreted, and patients with renal insufficiency have hemorrhaged badly on dabigatran. And SSRIs and SNRIs and mirtazapine make the list of drugs to be used with caution. It's not because of falls or osteoporosis in this case. They're actually citing their tendency to cause SIADH or hyponatremia. And they also offer a list of what they consider to be strongly anticholinergic drugs that should generally be avoided in the elderly. So dimenhydrinate or Gravol, diphenhydramine, and quite a lot of elderly people use that as a sleep aid. I think you buy it as what, Sleep Ease, is that? I think Sleep Ease is diphenhydramine. Hydroxyzine or Atarax. Paxil, certainly, Paxil is a pretty good drug, I find, for the young, especially young with anxiety disorders. But for elderly people, I'd much rather go with something like S-citalopram, for instance, the Cipralex.
Sorry, could you define young and old?
No, I can't, because it's more of a functional diagnosis than an age. But so I think let's, at the first inkling of frailty, say, or maybe at age 70 or something like that. But as I get older, my definition keeps changing. Olanzapine is quite strongly anticholinergic, and I've known that, and I've never used olanzapine as some people do for, say, delirium, because some people in hospital for delirium will use olanzapine or Zyprexa sublingually. I think it's a bad choice for delirium because it's so anticholinergic. Loxapine is too, for that matter. So actually, haloperidol wins top honors for delirium. Oxybutynin, toltridine, well, we're using a lot of that. And cyclobenzaprine, which would be Flexeril. Yes? Yeah.
Sorry, if you have somebody on paroxetine and you have to keep them on an SSRI, which SSRI do you think would be the safest?
My preference is S-citalopram or Cipralex. Yeah. And, if they were on paroxetine and you couldn't find anything wrong, and you didn't have a reason, I might not change that. But let's say that they've come to me because they've got cognitive impairment and they're on an anticholinergic drug. So the part of my treating their cognitive impairment is to get them off everything that's anticholinergic. So then I would do a switch, say, to S-citalopram. And I think we're getting awfully close to the end. Yeah.
Does this S-citalopram have less effect on the sodium?
I don't know that, and I don't think anybody knows that yet. we're kind of guessing that it does, because you know how they've got the two enantiomers, and you've got the R and you've got the S, and supposedly the S is the one that does the good things, and the R just contributes to side effects. Well, so you've got pure S and no R, so we're kind of thinking that you're getting the same effect with less drug and probably less hyponatremia, but that's only a guess. I looked into that once because I've got some patients who have chronic hyponatremia, but really need an antidepressant. It seems as though bupropion doesn't cause hyponatremia. Maybe it's just that it hasn't been studied enough, but I can't find any record of hyponatremia occurring in bupropion-treated patients. So that's what I've done is when I've been stuck that way, I've put them on bupropion.
It's interesting, I had a patient, a quite elderly lady who was on Celexa, and her sodium was quite low, and she'd been taken off the Celexa to improve her sodium, and her mood really deteriorated. And so everything I read was like, they all can drop your sodium. So I sent her to the geriatric psychiatrist asking for some guidance, and he put her on Rib-on-pelvis, which does the same thing. So her sodium stayed within normal limits and she's been on it, but she's on just a pinch and her mood's improved. But I was like, okay, well, they all can cause hyponatremia.
I think you'll find less with bupropion. Certainly,
Okay.
Remeron does, probably at therapeutic doses.
Yeah.
All of the SSRIs, the SNRIs, cause hyponatremia. Okay. Anything else you want to talk about? Oh, I think we're right on time. Okay. Cheers.